So let me share my screen here for a second. So these are kind of the topics we're going to go over. So today we're going to do uh, just kind of go over an overview of what to do if we have a decompensating patient, either in the step-down unit on the floor or in the ICU or in the ED. Dr. Shora and Magdalena next month, I think, are going to go over pre and post thrombectomy management, and they're going to actually do that a couple times a year. We're going to try and go over the decompensating patient management at least every year, if not twice a year, because those are important to just kind of reiterate. Um, EVD management troubleshooting we'll do in November, and then we'll add some other ones. But the goal is to do at least something every month along those lines. So the first thing I kind of wanted to talk about is the fact that the hospital, both the hospital and our department, has escalation of care policies. And so if you're not sure where to find um, policies. So the easiest way is you just go to the general intranet webpage that will come up when you open up a browser tab. You go to facilities, you go to Elmhurst, right? And that'll take you to the main Elmhurst one. So if you're on the Elmhurst web page, intranet page, you go to policies and procedures at the top. You can either go to Elmhurst there, which will take you. I guess that's actually also on the main intranet page, or you can go from the Elmhurst one. Another way is to go down. There's all, or actually, sorry, to click on quick links and to go down to where is it here, which is Elmhurst SharePoint policies. So probably the easiest thing is just to use the policies and procedure drop down at the top. And then this is where you can get all the policies and procedures at Elmhurst. There's an administrative manual, there's a neurosurgery, there's neurology. So for instance, if you go to click on neurosurgery, it has a bunch of just kind of administrative stuff. And then there's clinical policies here, including our escalation of care protocol, which we'll go over. Um, there's, spine trauma, management of severe traumatic brain injury, management of aneurysmal subarachnoid hemorrhage, management of patient with cerebellar infarction with swelling. Um, so these are all on here. Everybody should be, I guess a couple of these are duplicates, which I'll have to get rid of, but um, everybody should be aware of these and have read these in our department. There's really no reason why they shouldn't be kind of committed, most of them, to memory at least, or at least have read them and know where to find them if you have any questions on these patients. But we'll be specifically going over the escalation of care policy there, as well as under the administrative manual. There you can also search for these. There's also a hospital administration of or escalation of care one here as well, which is Administrative Policy 81. Um, Additionally, as we've discussed before, you can go to, if you're on the main Elmhurst page, you can go to also to clinical departments, and you can either go to cerebrovascular or stroke or go to trauma. I'll just go to the trauma one, and you can find all of their policies and protocols here as well. So clinical practice guidelines and policies for trauma are all listed down here, right? So if you need to, if you had a question about, say, um, well, whatever, say brain death, it will be up here, or uh, you know, TAG or anything like that, thoracic, uh, you know, pneumothorax, surgical areas, whatever. Some of these are obviously applicable to us, and some of them are more applicable to general trauma, but anything trauma related will be on here as well. So, in terms of escalation of care, so again, these are new policies that came into effect a little bit over a year ago, and just a reminder, these were directly related to um, a case here at Elmhurst where there was a patient that was a neurosurgical patient that was in the step down unit, where there was a feeling that policies could be revised and updated related to escalation of care. Um, and so the administrative policy for the entire hospital, um, as I mentioned, it has is relatively general and it applies to all patients in the hospital. We have a little bit more specific criteria in our departmental policy, but everybody should read both of these. In terms of the one from the main hospital, it basically says that that um, that basically the protocol establishes for safe and timely escalation of patient care issues. All employees should adhere to this policy for resolution of problems that would otherwise impact the ability to achieve the aim of providing the right care in a timely, effective, patient-centered, and equitable manner. You should follow the chain of command, which in our case is, escalation up to the chief resident and the attending, and if necessary, up to either the associate director or director of service. Policy prohibits punitive actions or negative evaluations or outcomes towards an employee or staff member as a result of bumping up an issue. Basically, this is saying, we can't get mad at you for bumping things up that you are concerned about, because we want you to bump things up as expeditiously as possible. So, everybody should read the administrative one. I'll go over in more detail, actually, our department one, because our department one's a little bit more specific. But in particular, right, the whole purpose of any escalation of care policy is to kind of formalize the expected rapid escalation of care for deteriorating, in our case, neurosurgical patients, to more senior members of the care team. The old adage is you never want to you never want to be holding a hot potatoes, and in terms of our department and in neurosurgery, you never want to be the uppermost person who has any sort of bad news about a patient or concerns about a patient. You always want to bump those up sooner rather than later, so up to at least the up to the attending level, so that the attending is aware of anything that could potentially impact the patient. Oh, sorry, I may have gotten rid of that. Sorry because I moved the screen. So let me put it back here. Can you guys see this escalation of care protocol? Am I sharing it properly?
Yes.
Yep. Okay. Um, so again, I won't read it verbatim, but an important aspect in managing a deteriorating neurosurgical patient is the rapid escalation of care to more senior members of the care team, to help with the assessment of the patient and to help with the management of the patient. So if a neurosurgical patient has one or more of the following signs or symptoms, then the neurosurgery chief resident and the neurosurgery attending of record, that's either the neurosurgery attending on call or the neurointensivist, or if the neurosurgery attending of record is not available. So if it's my patient, it should be me. But if I'm out of town, then it should be the neurosurgery attending on call and or Dr. Capinos if he's on. But basically, it should be an attending that could help manage the patient. The expected time frame for the notification in emergency situations really should not exceed 20 minutes. It shouldn't take that long to at least do an initial assessment of somebody that's decompensating on the floor in the step down unit or in the ICU, and then escalate that as appropriate. It doesn't mean you have to have all the information, but you should have some information and have seen the patient physically, and then escalate it. So if a patient's in a non-ICU setting, so step down unit or the floor, then a code or resuscitation team should be activated if the patient requires cardiac or respiratory resuscitation or may require emergent intubation. And then if a patient is already in the ICU setting, the code resuscitation should be activated if the ICU and or primary team requires assistance and deems necessary. So for instance, if like a patient's in the PACU and we need help, then we think that the patient might need to be intubated, or the patient might need vasopressors, or anything that, or the patient, is peri-code in some other fashion, we think they might be heading toward the cardiac arrest, then you should be calling the code resuscitation team. But you shouldn't have basically any qualms about calling a code resuscitation team if it's needed. Don't let a nurse or anyone else tell you that you can't call them. That, when it comes to this sort of thing, again, we frankly outrank them, and we are ultimately responsible, and our department's also ultimately responsible. And so if you think somebody it needs to be emergently intubated, might need emergent vasopressors, is highly unstable, might need respiratory resuscitation, even if you're bagging the patient, then you should call basically a code resuscitation team, a medical alert team to help, as well as escalate it to the chief resident and attending. So kind of some of the triggers for escalation of care, and these are changes from the patient's baseline status, meaning, the way they've been in the last like 24, 48 hours. So if a patient has a decrease in Glasgow Coma Scale of 2 or more points, or other substantiated decrease in consciousness. So, if a patient goes from following commands to not following commands, or his patient was, GCS 15 and now they're like a 13 or 12, that's something that should be escalated. Again, there are other scales such as the Richmond Agitation and Sedation Scale. So if that decreases by 2 or more points, an unexplained decrease, that should be escalated. Again, increase in NIH Stroke Scale of 2 or more points. New or worsening neurological deficit. So again, if were following commands, no longer following commands, if they're now plegic in one limb and they weren't that way before, or significantly weak in one limb and they weren't that way before, that's something to be escalated. New or repeat seizure or status epilepticus. Those are things that should be obviously escalated. Intracranial pressure elevation, so ICP elevation for greater than 5 minutes, based upon parameters that we set for that patient. So again, if it's 20 or 22 or 25 in some cases, if it's above that for more than 5 minutes, kind of sustained, that should be escalated as well. Similarly, through perfusion pressure that's definitely below 60 should always be escalated. The reason we put that in is because pretty much, less than 50 is the ischemic threshold. So, unless we pretty much never want the cerebral perfusion pressure less than 60. Sometimes we might want it higher, but basically never do we want it lower. And so that should be another trigger. New brain tissue oxygen pressure of less than 20 when it was previously above 20, and now it drops down less than 20 for more than 5 minutes, that should be escalated as well. And then, just general, obviously, other vital signs that are important. So if your oxygen saturation is below 94% when it wasn't before, or we have to increase the amount of oxygen supplementation we're giving a patient. So, if they're on just nasal cannula and we have to escalate to a non-rebreather mask or high flow nasal cannula, those should be escalated as well. Um, Arterial pressure, arterial partial pressure of CO2 that is, widely out of range, either in the severe hyperventilation range or severely hypercarbic. If there's airway obstruction, stridor, abnormal respiratory pattern, if a patient's hypoventilating or excessively hyperventilating, if they're very bradycardic or quite tachycardic, or if they're hypotensive or very hypertensive. Those are all things that generally, if that's a change from before, are indicating that there's something likely new going on, and potentially something very significant. And so those are all things that should be escalated to the chief resident and to the attending. In addition, the neurosurgery attending a record, or again, the neurosurgery attending on call, or the neurointensivist, if the neurosurgery attending of record isn't available, should be notified really within 30 minutes of any emergency neurosurgery consult or admission. Non-emergent consults and admissions should be staffed within 60 minutes. And then additionally, other things that the attending needs to be aware of is if there's a need for escalation of a patient to a higher level of care. So if they need to go to the ICU from the step-down unit, or to the step-down unit from the floor, if there's any new or worsening finding on any imaging. So again, if we have a patient that we are getting a routine head CT on, one, we should be double checking to see when that head CT is completed. So if the patient is on the floor, we should be, the first people, the PA holding the pager to deal with floor patients, and should be checking that kind of basically like every hour or so to see if that scan's been done. And if once that scan's been done, they should look at that scan, and then they should tell the chief resident right away that the scan has been done and review it with them, so if there's any new or worsening finding on that imaging, that it can be escalated up to the attending in a timely manner. Really, anytime any imaging is done, the attending should be made aware of it sooner rather than later. What we want to avoid is a situation where we're coming in on rounds the next morning and finding out that there is imaging done that shows a significant change from prior. And ideally, we don't generally don't want to be coming in the morning and be told that imaging was done, 6, 12 hours ago. We want to be told that was done, within, an hour or so of that imaging being completed, even if it is normal. Because, reading these scans and is something that is, uh, that skill is gained over time, and people can miss things. And so it's important for the attending to be aware of any imaging that's done on a patient that might be relevant to us sooner rather than later. But certainly if there's a new or worsening finding on it, it should be escalated quite rapidly. Uh, New or worsening critical lab values, including, critical ABG values, any new adverse patient events. So whether that's a DVT, a PE, a fall, that's something that should be escalated. Again, I would put, any issues with surgical drains, things like that. Those should all be those would under be a new adverse patient event. Those should be escalated as well. If there's an issue with the vascular puncture site, reduction or loss of a previously palpable extremity pulse, excessive blood loss that's not easily controlled, severe new or uncontrollable pain, severe new or uncontrollable nausea. Those are all things that should be escalated to the attending relatively rapidly within 30 minutes or so. Um, and again, one of the most important things about communication is using closed loop communication. So that's vital, for the accurate and timely transfer of critical information, particularly in an emergency. So what this means is that when possible, always the preferred method of communications either is verbal communication, either in person or via telephone. Um, Texting, while can convey information rapidly, you need to be doubly careful about that, particularly in an emergency or with something urgent, and you need to make sure that the person receiving it not only received it but has read it and understood it. And that's why, in an emergency setting or for something urgent, usually in person or via telephone is preferable and should be the kind of default mode of communication from PA to resident and from resident to attending. Um, if you use a nonverbal, i.e. text communication, then it needs to be rapidly followed up if you haven't, via telephone call, via or in-person communication, if that text hasn't been confirmed to be received and understood and responded to by the person that you are sending it to. So it's not a good idea, in this situation. It's like there's a CT scan, for instance, with a finding on it that is new, to just post it in WhatsApp and assume somebody's going to see it or respond to it. What you would want to do is, in that case, is you could post it in WhatsApp so people see it, and then immediately call the chief resident so that the chief resident is aware, and then the chief resident should then look at it and then immediately call the attending. Um, and uh, and if the attending is not available, then call the attending on call or call the associate director or the director of service about the patient. But really, in those situations, a call or in-person communication is always preferable. Um, and again, if individuals are in the OR, that means that's the preferred mode of communication. That means that PAs should be coming into the OR to directly talk to the chief resident and or attending if they're in the operating room. And this is all to avoid errors and ensure a timely response. Um, so please, make sure you read over this escalation of care protocol um, um, the Elmhurst Share Plus policy area, and then also read over the administrative policy as well. Are there any questions about either of those? All right, so I'm going to share my screen, and let me actually just stop sharing for a second. Let me see what's better. Let me share this one.
You may want to add the drain malfunction to the list of the events that should prompt an escalation
Yeah,
within
yeah,
30
I'll,
minutes.
I'll add it more specifically as well. Uh, but yeah, I think, I think the only reason it wasn't in there specifically is it should go without saying, but obviously we'll be more explicit and add it and update it. Um, But so with that, wanted to go. This is again a presentation that we went over last year. You know, I definitely will be adding to this over time because there's a lot more that we could add to this. But we just kind of wanted to go over the ABCs of how to manage a decompensating patient. Um, so, the first thing is to realize that, neurosurgery patients are not your typical patient in the hospital, right? Neurosurgery patients are much more complex and are at much higher risk of decompensation than patients on other services, um, except for maybe patients that are in the ICU already. But these aren't plastic surgery patients. These aren't just kind of regular general surgery patients. These are patients that have something usually abnormal with either the with the CNS, either the brain or the spine, and they're high risk of decompensation from a neurological standpoint. That might be worsening hemorrhage, worsening edema, stroke, or seizure. They often can be at high risk, partly due to that, for respiratory decompensation, whether that's respiratory decompensation because they have something that's secondary to the neurological decompensation, or it might be because they have a trauma and have now a pneumothorax or a hemothorax or a PE, or it might be related to sedation that's being used to help manage their neurological condition. Um, we also, as the population is getting more elderly, we have more neurosurgery patients that are elderly as well, and we have more cardiac risk. So we have patients that with pre-existing cardiac disease, patients that have been on, antiplatelets, on anticoagulation, um, patients that may have chest trauma, aneurysmal subarachnoid hemorrhage patients often can have cardiac issues related to the sympathetic outflow from their hemorrhage. Same with trauma patients. Stroke ICA patients obviously tend to be older and often are vasculopaths and have cardiac risk factors as well. And then, perhaps less common, but our patients are at risk of decompensation due to infectious issues, whether that's sepsis or patients that have shunts or intracranial lines might have an intracranial or shunt infection or a spine infection. So the first thing is, having a high, um, index of suspicion and having a respect for the fact that, our patients are all at high risk of decompensation and um, you know, not brushing things off as not urgent when they potentially could be. So again, we kind of went over the criteria for decompensating patient, but anybody that has a decline in their Glasgow Coma scale of more than a point, or has a new or worsening neurological deficit, so a new face or arm weakness, no longer following commands when they were following commands consistently before that, an increase in their NIH stroke scale, an adverse change in their vital signs, becoming newly hypotensive or hypertensive, low or high heart rates, a new arrhythmia, things of that nature, low respiratory rate, high respiratory rate, um, uh, new hypoxemia that wasn't there before, um, a newer escalating requirement for supplemental oxygen, um, and need for a higher level of care. So these are all criteria. This is not as extensive as what we had in the escalation of care policy, but just wanted to drive home the point that these are all things that should be escalated to the chief resident and then rapidly to the attending as well. So the first step is if you get called by the nurse about a patient that has any of these things, or they're concerned that the patient um, has had an adverse change in their clinical status, the first and foremost priority is to go and evaluate that patient. Yeah, you shouldn't. This isn't a situation where you should, just look at Epic or open up Epic and give recommendations and then not see the patient. You could certainly open up Epic and glance and see like what's been going on and see if there's anything obvious and make some initial recommendations, but you should go and evaluate that patient essentially immediately, and see what's going on with your own two eyes. And when you're there, what you want to start doing is going through, what we would always do with any trauma patient or with any cardiac arrest patient or with any decompensating patient is to assess the ABCDs, right? So assess first their airway, see, get a sense of whether or not their airway is patent or not, whether they're protecting their airway or not. They might not be protecting their airway now if they've had a rapid decline in their mental status and are no longer um, are now either comatose or stuporous and they were wide awake before. So even though their saturations are normal on the bedside monitor, they might not be protecting their airway well, and they might be at risk not only for aspirating, but then for having a rapid decline in their respiratory status um, right away. And in some patients, they may not have a patent airway and they might need immediate intubation. So that's the first thing. The next thing is to look at their breathing. Is it sufficient? Is it normal breathing, or is it distressed or agonal breathing? Get a sense of the rate because in a lot of patients, patients that are having a respiratory issue, if their airway or breathing are compromised, you might be able to rescue them just by doing bag mask ventilation. Getting an ambu bag and putting that on them and um, helping supplement their breathing and their airway by adjusting, obviously the airway you would, do a head tilt chin lift if they don't have any cervical spine issues. If you're concerned that they have a cervical spine issue, say they just fell out of bed or something like that, you would do a jaw thrust. Um, but opening their airway and potentially giving um, respiratory supplementation with an ambu bag may be enough to save that patient. It might be the case again that they need a more advanced airway like intubation, and you shouldn't have any qualms again about a patient where you're concerned about either their airway or breathing, about calling a medical alert code for a stat airway, stat intubation. It's always better to be more aggressive than less aggressive, right? So I'd rather patients get potentially intubated that may not have needed it than a patient not get intubated that definitely needed it, right? You always want to err on the side of being more aggressive about your escalation of care than the other way around. Um, then in terms of evaluating the C is for circulation or cardiac. You want to check their pulse and their heart rate and their blood pressure and make sure those are sufficient. And then D is kind of disability or dextrose. You want to check their finger stick, make sure that they're not hypoglycemic. Check their neuro exam and get as good of a neuro exam as you can at that point. And again, this doesn't need to be super thorough. What you really want, we'll go over what you should be assessing, but really it's going to be assessing, their mental status, um, and assessing, to make sure they don't have any significant new neurological deficit that wasn't there before. Then you want to escalate to the chief resident and the attending promptly, again, within, ideally 10 to 15 minutes or less. If you don't think that they need an emergent airway or need vasopressors or something like that, then you can call a rapid response team. Now, re realize that we don't have a rapid response team here at Elmhurst 24/7. And again, this, this really kind of assessment requires you to be pretty confident that they don't require anything additional. So when in doubt, you can call they changed the name of this. It's no longer the cardiac arrest team. It's called a medical alert team. But if necessary, call the medical alert team and always err on the side of doing that rather than a rapid response team if the rapid response team is not there or if the patient is severely decompensating. So if you think that this patient, needs any sort of basic life support, like you're having to bag the patient now with an ambu bag, or they're having an arrhythmia, or they're potentially going to require intubation or vasopressors, then just call a medical alert. It's just safer and quicker and easier. So there's, a rapid response is really for a patient that is their vital signs and their um, at least at Elmhurst, this is different than Sinai, right? But a rapid response team at Elmhurst is really for a patient that's not so unstable that they're going to require that they have a lot of vital sign instability and they're like unlikely to need an escalation of care and they're unlikely to need intubation or vasopressors or whatnot. So when in doubt, always go for the more kind of aggressive resuscitation team. It's just, it really speeds things up and ensures that everybody's there that needs to be there. So again, when you assess the patient at the bedside, first thing you're going to want to do is assess their mental status. Be aware of any confounders. So if they just got paralytics for whatever reason, this is more kind of common in the ED where they might have just emergently intubated the patient. But be aware that those could be compounding or confounding your physical exam. If etomidate as a half-life, this might be a mistake. I think it's a little less than that, but 75 minutes, rocuronium, half-life of almost 2 hours. Uh, uh, Sorry. Just, if people can just make sure to mute themselves if they're not muted. Um, Other confounders are hypotension, hypoxia, um, pupillary exam is the other thing that you would want to get after assessing their mental status. See if, sorry, one second, just gotta pause this for a second. I think that's Dr. Bayan's. Hang on one second.
Maybe you can use Dr. Ryan.
Yeah, I gotta pop out of this to do it. Yeah. There we go. Let me just reshare. Which one do you guys see? Do you guys see the full thing, or do you see my presenter mode?
No, not presenter mode.
Okay. So then you want to, particularly in neurosurgery patients where there's always a chance for a new mass lesion and potential for cerebral herniation. So after getting a sense of their their mental status, which in a decompensating patient is really kind of like the primary thing to first get a handle of. Always make sure to check their pupils, see if they have reactive pupils or if they have either a unilateral or bilateral fixed and dilated pupil. Obviously, that's a sign of potential herniation or potentially anoxic injury if they have both pupils fixed and dilated, and that's obviously something that would be indicative of something that very serious going on that needs to be potentially intervened upon rapidly. Sorry, what is this? Okay. Um, I think I don't want to belabor this, but we should all know how to do a Glasgow Coma scale. It really looks at level of consciousness. It's not that's the main reason for it being developed was to um, make a more objective scale rather than the typical kind of descriptive scales of alert and lethargic and stuporous and obtunded and coma. It was an attempt to basically standardize that by looking at the eye response, the verbal response, and the best motor response, and combining those to get a value of either from 3 at its worst to 15 at its best. So eye response is out of 4, verbal response is out of 5, and really relates to orientation, and the best motor response is really the most important in a lot of our patients, particularly those with severe TBI. Any patient in a coma, really their motor response is just as indicative of their kind of outcome as the best motor response. Importantly, this wasn't developed to predict outcome in any way, shape, or form. It's really just a scale like any other consciousness scale, just really to describe the level of consciousness. And while the overall value is important, it's also a good practice to report each of the individual ones because a patient that has a GCS of 13 or 12 can have different combinations of these, and those can be, if a patient is widely alert or with their eyes open, but has a poor verbal response and a poor motor response, that may mean something different to the chief resident or the attending than the opposite. So a GCS of less than or equal to 8, so 3 to 8 is typically defined as a coma. And that also is the definition of a severe TBIs or patients with a TBI that are in a coma. And it has been shown to correlate with outcome, but that wasn't the initial intent of the Glasgow Coma Scale. So again, I won't belabor this point, but eye opening, if they have spontaneous eye opening, meaning they're, you don't have to speak to them to get them to open their eyes, and that's a 4. If you're telling them, open your eyes and they do it, or you make a sound and they open their eyes, or you start talking and they open their eyes, that's a response to speech. That's a 3. If they don't only open their eyes to some sort of noxious stimulus, whether that's a supraorbital pinch or a trapezius pinch, then that would be a 2, and if they don't open it, that's a 1. Um, in terms of motor response, and I usually report these eye first, and then motor second, and then verbal, because verbal's kind of the least reliable usually often. Um, but motor response, again, particularly in a patient that's decompensating, is often in some ways the most important, because this will give you a sense of whether they are still following commands. So if they're following commands, again, that's a 6. So that might be showing 2 fingers. Um, it might be, you could asking them to lift up their leg and then actually doing it. So they're ideally, you want to do something like show 2 fingers or show 3 fingers, but sometimes they might not be able to do something quite that complicated. But if they are if they're with their motor response, if they are obeying a command and mimicking it, then or doing that command, then that would be a 6. If they are not following any commands, it's going to be somewhere between a 1 and a 5. If localizing is basically if you give them some sort of noxious stimulus, say a better one would be actually if they did on the opposite side. But generally, if they're then moving, usually it's their arms. It's very hard to localize with your legs, but usually with your arms. Um, if you are then reaching towards that stimulus, and technically it's supposed to be kind of across midline and above the nipple line with your hand in order to be counted as localizing. Withdrawing is if you provide a noxious stimulus to their limb and then they try and move the limb away from the noxious stimulus. So this is one of those kind of times when you might need to do nail bed pressure to see if they withdraw. Um, that's a 4. In general, when we apply noxious stimulus, we want to generally do either supraorbital notch or trapezius pinch. It's a good idea to kind of avoid doing sternal rub. And because, particularly in trauma patients, they may have sternal fractures. It also sometimes, we've had instances where family members have viewed that as, particularly if you're doing it on a woman and you're a male, they may view that as, um, you know, um, and, being too close to their breast or whatnot. So it's just better to avoid a sternal rub if you can avoid it. Supraorbital notch or trapezius pinch is usually a good one to do because it doesn't appear to be too noxious. Or um, if you need to do sternal rub, um, it's best just to make sure that any family members are aware if you need to do it, and ideally have like a chaperone if it's a woman and you're a man doing it, just to make sure that there's no um, misconstruing what's going on there in terms of the exam. Um, Abnormal flexor response is if you have flexor response in the arms, and then usually extensor in the legs, and then extensor response of 2 is extensor in the legs and arms. And so um, you know, again, these particularly 1, 2, and 3 are often signs of kind of severe brain dysfunction. So something potentially serious going on. This I put in there because you kind of, again, along with a sternal chest rub, we want to avoid things like nipple pinches, things like that. It's not a good way to um, test noxious stimulus. Generally, supraorbital notch or trapezius pinch are probably the 2 best. And then to test withdrawal, you'll probably need to do some sort of nail bed pressure if you have to, but try and kind of keep it to the minimum necessary. Verbal response again is if they're fully oriented to month and year, then there would be 5. If they um, are verbal but are confused, but it is an error in that, then it would be a 4. If it's completely inappropriate words so that they're not responding with uh, that you can understand them, but what they're saying is completely inappropriate, then that would be 3. If they are making sounds but they're not making words, then that would be a 2. And if no response, again, that's a 1. Um, After assessing their mental status and their pupillary exam, again, you would do a focused neuro exam You don't need to test all the cranial nerves, but you should probably sometimes there may be one or more of these that might be important to us. So, for instance, if we did a surgery, for like a vestibular schwannoma, you would probably want to test the facial nerve. We often wanted to look at and see the symmetry of the face anyway, because that could be a sign of a patient that's having a stroke if they have any um, uh, facial asymmetry that wasn't there before. It's pretty quick in an awake person, at least, to test the ocular motor nerve as well as the trochlear and abducent nerves. So you could do that. We often, will skip over some of the obviously the lower cranial nerves, such as the spinal accessory nerve. But if you're able to do these, great. But again, it should really kind of be tailored and focused to um, the particular patient and pathology. And then do, a motor exam in all limbs. And, I said detailed here, but really, for a particular spine patient, you'd want to be as detailed as possible. But in a decompensating patient, they might not be, um, if they're meant, you can only do as detailed an exam as their mental status will allow. So, the reason why it's very important to both assess these patients and escalate it as quickly as possible is because, in most cases, what we're trying to avoid is, most of these patients have some sort of primary injury, whether that's a TBI or a stroke or, an ICH or some form of initial injury to either their brain or spine. And we want to avoid additional injury on top of that. And um, things like hypotension, hypoxemia, decreased cerebral blood flow, new mass lesion causing cerebral herniation, those can all cause additional injury, which would convert a primary injury into a secondary injury. So we can't really do much about the primary injury. We're trying to avoid secondary injuries in these patients. And particularly, like I said, our patients are at risk of neurological decompensation, but they're at extremely high risk of respiratory decompensation as well. And if they decompensate respiratory wise and have hypoxemia, or that leads to then hypotension from their secondarily to their respiratory issues, that can lead to significant secondary injuries. And secondary injuries, really impact the outcome of neurosurgical patients. There's been a lot of research on this, particularly in TBI and severe head injury. But basically, morbidity and mortality is dramatically increased when a patient has either hypotension or a combination of hypotension or hypoxia. And so that's generally what we're trying to avoid. Um, so, again, this kind of comes more from our TBI literature, but, we want to maintain, again, you want to make sure that, in general, our patients are hypotensive. In most patients, it's going to be a systolic of greater than 90. In TBI, we generally will keep them a little bit higher if they're severe TBI. So these, again, are severe TBI numbers. And, you want to make sure that a patient's oxygenating well enough. You want to keep their head of the bed up. If we think they're having any respiratory issues or they might have a lesion in their brain, again, anti-epileptics if they need them. Um, so in terms of, a decompensating patient, once you've established the ABCDs, and again, that might require intubating the patient, by this time, obviously, the chief resident and the attending should be well aware of what's going on. Again, if necessary, the chief resident and the attending should come in, particularly if the patient looks like they need to be emergently intubated or escalated of care. A medical doctor needs to be involved and see that patient. It's not really sufficient for the PA alone to see the patient. And now sometimes that's going to be if the SICU is involved or the medical alert team is involved, then the intensivist, if the intensivist sees them, then that can suffice. But there should be a very low threshold for somebody from our team, either the chief resident or the attending, to come in a patient that is decompensating rapidly and needs an escalation of care because that patient may, uh, you know, need an additional neurological assessment. They may need additional management, and it's very hard to do that kind of remotely, so very low threshold to come in and see the patient. Um, Obviously, the next step would be to get generally a CT head without contrast, sometimes an MRI, but obviously in a decompensating patient, we tend to err on the side of more rapid imaging, and so a CT head without contrast, if it's related to something going on in the brain. Again, if it's the spine, we might have to get an MRI as well to look and see if there's something neurological going on that we might need to be intervening in. Again, somebody that decompensates rapidly, probably, unless you just had a CTA of the head, it's probably a good idea to get a CTA of the head if it's a TBI or a stroke patient or an ICH patient to make sure there's not a cerebrovascular cause of their decompensation. Um, so, again, this is a bundle that was put together that I was involved in for TBI, but it kind of, it applies to a lot of neurosurgical patients, but at least cranial patients. But, you really want to always avoid and treat hypoxia, avoid and treat hypotension. Don't hyperventilate them unless you absolutely need to. And even if you do need to hyperventilate them, keep it to mild hyperventilation. Evaluate and treat any intracranial hypertension. That don't use steroids obviously only applies really to TBI. If a patient has a tumor, you might need to use steroids, but particularly this beginning part is important. There's basically no time when we want any of our neurosurgical patients to have any sort of hypoxia or hypotension, and those are the things that really cause secondary injury in particular, along with untreated intracranial hypertension. So it's important to, speaking of herniation, cerebral herniation, it's important to recognize it. So a patient that, is newly comatose, or a patient that has unilateral or bilateral fixed and dilated pupils, a patient that's posturing, so either having flexor posturing or extensor posturing or no movement that was previously had a better motor movement than that, either following commands or localizing. Those are all signs of a patient that could be potentially herniating. So what you would want to do in order to kind of temporize their cerebral herniation, the reason why I say temporize is these are all maneuvers that can be done emergently, but oftentimes it's going to require a more potentially more invasive way of correcting the cerebral herniation, either through surgery to evacuate a mass lesion or decompress the brain in the case of severe swelling, or it may, if they don't have those and if there isn't a surgical option, then they might need a monitor place and then kind of more focused hyperosmolar therapy. But you'd want to do brief hyperventilation, so respiratory rate of around 20 to 25 in that range, but you're really targeting a PaCO2 really more around 30. Oops, 30 is kind of the ideal. You don't want to dip below 25, so 25 to 30, but aim kind of for the upper of that range if possible, and then hyperosmolar therapy. So either mannitol, 1 kilogram per kilogram bolus that's pretty easy to obtain on the floor. It's also can be given peripheral IV. The issue with mannitol is because it's a diuretic, it can cause hypotension. So it's generally not our preferred method. Our preferred method is hypertonic saline. The issue with hypertonic saline is it often needs to be given through a midline or a central line. It can be given through intraosseous line if that's been placed, and we are changing the protocols and policies at the hospital to make it so that we can give it more readily through a peripheral IV. Realistically, if you need to give it through a peripheral IV, give it through a peripheral IV. It should just be given by the PA or an MD. We are again trying to change the policy here at the hospital so that it can be given by a nurse through a peripheral IV, but right now, at least for right now, they often won't do that, and it'll need to be given by a PA or an MD, and you just need to make sure it's not extravasating and give it over about 5 or 10 minutes slowly. But usually we use the 30 cc's of 23%. If you do use 3%, then it should be about 250 cc's to equal the same amount of sodium. So the reason why it's typically our go-to though is hypertonic saline is a volume expander, so it maintains a patient's blood pressure and cerebral perfusion pressure better than mannitol typically. So um, other than the kind of the requirements for administering it, it's usually a better option than mannitol. But it's okay to use mannitol if you can't give hypertonic saline. But the one situation when probably wouldn't give mannitol is if they are borderline blood pressure or already hypotensive. That's when you wouldn't want to give it. Um, so some just kind of shifting gears a little bit, but some important components that we've about consult notes that I wanted to reiterate, partly because it's our ACS trauma reporting year, which we have a couple more months still in our reporting year, and then we'll be doing our re-verification in the spring. But it's important that we make sure that we're always filling out the time that the neurosurgery consult was called and the time the consult that we arrived at the bedside to evaluate the patient. Ideally, if you can get the information on the GCS in the field, sometimes that's in the EMS notes, sometimes the trauma team will have that, or the ED will have that. But definitely the GCS on exam, the mechanism of injury if it's a TBI patient, medications, allergies if possible. It's always important to make sure that we're double checking whether or not the patient is on any antiplatelets or anticoagulants and reporting that to the chief resident and the attending. Any past medical or surgical history that's relevant, additional traumatic injuries if it is a trauma patient, the assessment and plan, and then the fact that it was discussed with the chief resident and the attending. And I think I've mentioned this before, but it's important to, while you can certainly get your note uh, ready and then penned it. Don't sign off on it and make it official until the chief resident is discussed with the attending and then relayed the plan back to the PA. So really, once you sign it, that should kind of be the final note where the chief resident it's already been discussed with the chief resident. Chief resident is discussed with the attending and confirmed the plan, and then the chief resident conveys that back down to the PA. And it's always good. That's always a good opportunity to double check with the chief, like which attending it was staffed with, so that that information is also correct in the consult note. And then any changes can be made to the assessment and plan, and then it should be signed at that point. Doesn't mean that you can't convey kind of initial recommendations verbally to the ED or whoever is asking for the consult, but really the note should be signed after the plan is finalized. So some important points we're going to finish in a few minutes is that um, accurate assessment and triage um, uh, to avoid, and part of this is, any decompensating patient or any new consult, it's important to physically see the patient, definitely need to, if you nurse is calling you about a concern for a patient, nothing replaces the information that you can get from and garner from seeing the patient and assessing them, as rapidly as possible. Avoiding hypotension. So in TBI patients, it's really 100 to 110 to kind of start with. We typically say 110 just to make it easier. In other patients, it's going to be systolic of less than 90. Avoiding hypoxemia in patients and correcting these things if you find them. Again, don't hyperventilate patients if they don't need it. And then, managing and temporizing and then definitively managing cerebral herniation if they have any. All right. So that's it. Anybody have any questions? I know in the future I will go through and update that a little bit so it's a little bit more specific to decompensating patients on the floor or in the step down unit. But any questions about kind of the main things to do if you run across a patient on the floor of step down that's decompensating? Again, just remember your ABCDs, assess the airway, breathing. If there are two PAs on, that's a scenario, right, where you probably want one PA to stay at the bedside, to, potentially, give rescue breaths with an ambu bag and um, if the patient seems to be having respiratory issues, be staying with the patient and helping manage the patient. And then the second PA should be relaying things to the nurse and putting in any orders that are necessary and calling the chief resident and the attending. Um, because, when you have a decompensating patient, it often requires more than one pair of hands. And so that's when, both PAs, if there's two PAs or more on, should be working together to make sure that everything is being taken care of as quickly as possible. And the best way to do that is to have one that's staying at the bedside, actively treating the patient. The other one is doing all the things like the phone calls and any orders that might be needed and things like that.